Hi guys, this is Dr. Patil here, and today we are connecting to learn or discuss the recall questions of the INI SS Neurology. Now, the important objective of this recall session is not to make sure that we had the exact same kind of questions or we had the exact same kind of options and get a score for ourselves, right? So the main objective of doing such recall sessions is we get to know the trends. Now that is very, very important because we know that all of us are not definitely getting into the seats. Right, so some of us will continue our journey onward to crack the super specialty entrance examinations. So identifying these trends are very, very important. What kind of questions are being framed? What are the topics which are emerging and becoming relevant? Right, this is what we should be focusing on. So the main objective of doing this is to identify the trends, understand what are the important topics. Right. So with this background, let me start with the first question for the day. What is it? The first question was: a 2-year-old child was brought with episodes of atonic falls and clonic movements. I'm not sure exactly this is how the question was worded, because obviously when we do recalls from mouth to mouth, the questions and the wordings keep changing, right? But at least in summary, this is what the question looked like. A 2-year-old child with history of episodes of atonic falls and clonic movement. What is the most likely diagnosis, right? Okay, so whenever we have questions which starts with a particular age, right, we should always pay attention to that age, right? And when we read various disorders, I always urge the students to read from epidemiology, right? Epidemiology, at least when we are sitting in the era where questions will be clinical, story will be there, right? Epidemiology, at least one finding, one point about epidemiology of a disease would be there in the clinical questions, right? Okay, so in this question, they have told that it is a 2-year-old child. With this information, I can directly rule out option D, right? So childhood absence epilepsy, usually the onset is 3 to 8 years. Some books even mention 4 to 8 years, right? Not at the age of 2 years. So this is directly ruled out for me. This is not the right answer. Now we are left with 3 options: Lennox-Gastaut, Douze and Dravet, right? Now among this, I will again rule out Dravet syndrome, because in Dravet, very often there is a history of febrile seizures. So the onset of seizures is in the form of febrile seizures, and then later on the other seizure types start appearing, right? That too more of myoclonic seizures. So that is ruled out because here they have not given the history. Now I have to make a choice between Lennox-Gastaut and Douze, right? Now when it comes to Lennox-Gastaut and Douze per se, right, the differentiation between this becomes a little tricky. But one particular thing we know, that myoclonus is more common or more strongly seen in Douze. Lennox-Gastaut, you will find various resources where they mention that myoclonic epilepsy is also seen. Right? They mention that, so the clonicity is something that is mentioned, but it is quite less common, right? So that is why I would, as of now, rule this out and take option B as the right answer. I hope we are making justice to the question. Right. Before we move to the next question, we'll just take a quick look at some important points, because now we know that this syndrome and differentiation is an emerging topic, right? Okay, so when it comes to Lennox-Gastaut syndrome, it is characterized by a triad of the drug-resistant seizure types, that usually multiple drug-resistant seizure types, intellectual disability. The intellectual disability may not be there at the beginning of the seizure episodes, but eventually most patients become intellectually disabled, right? So a triad of intellectual disability, multiple drug-resistant seizure types, and EEG findings, which are relatively characteristic. Less than 3 Hz, usually 1.5 to 2.5 Hz, spike and wave activity with paroxysms of fast activity in the range of 10 to 20 Hz. This is what is characteristically seen, right? So less than 3 Hz. Okay, so this is the triad of Lennox-Gastaut syndrome. I've already told you that intellectual disability is not the initial finding. So patients may have a normal developmental milestone, especially with respect to intellectual, till the onset of seizures, right? Okay, now the most important area to focus here is the type of seizures that we see, right? So these patients can develop tonic seizures, which is the most common, right? This is again an important MCQ point. What is the most common seizure type in patients with the Lennox-Gastaut syndrome, right? So tonic is the most common. Other than that, yes, this is also known to have drop attacks. Atonic seizures are common. Patients can have the atypical absence seizures, right? Not the typical absence seizures. Atypical absence seizures, these are the second most common seizure types. Okay. Then patients may have, so this is the controversial point, because I have come across various resources where they mention myoclonic seizures, but then I have also come across some internet resources where tables are there comparing the Lennox-Gastaut with the Douze, where They characteristically mention myoclonic with the do's, and they don't mention that in case of Lennox-Gastaut. But at least this much is clear. This is not very common. That is relatively rare. And in case of do's, it is very common, right? So with that point, we could come out with the answer in the previous question, right? Okay. Patients can also develop tonic-clonic. Now, the onset of the seizures is usually in 1 year to 7 year period, right? And the peak is usually reported at 3. So we are rightful in considering Lennox-Gastaut as one of the important differential in this question, because the age of this patient was 2 years, right? So 1 to 7 years is the presentation window. So from the age point, only option D could be ruled out, right? Okay. Now, coming next to the Douce syndrome, right? So there are only 2 or 3 important points for us to learn here right now from Douce syndrome. The point number 1 is this is also known as MAE. That stands for myoclonic astatic epilepsy, right? Myoclonic astatic epilepsy. Typically, these patients have myoclonic seizures or myoclonic atonic seizures presenting with drop attacks. And the age of onset of seizures is again usually 1 to 5 years, right? Okay. So now you may ask me, yeah, we have already discussed, right? So the Dravet, there is a characteristic history of febrile seizures. Dravet syndrome is an again important topic, right? So from Dravet syndrome, we should remember that the onset of seizures are usually within 1 year, right? So the previous things we were talking about are after 1 year, right? 1 to 5 years, 1 to 7 years. Yes, a little early can occur. That's not a hard and fast rule that says that it shouldn't occur in the 11th or 10th month. But generally 1 to 7 years or 1 to 5 years for LGS and DOS. But in case of Dravet, it is infantile, right? Usually within 1 year. Most cases are presenting within 5 to 8 months of the age group, right? The initial seizures are characteristically febrile seizures, but they differ from the typical febrile seizures that we routinely see in 2 features. The feature number 1 is they're usually prolonged, often lasting for more than 10 minutes, right? And in fact, most cases, the first seizure is following some vaccination, right? Patient develop a febrile illness following vaccination, and then the first fit throws up, right? Okay. And these seizures are often unilateral. Right? So this is one important point for us to note here, right? So they are often unilateral. Atypical febrile seizures, prolonged duration, and unilateral, right? These are important features. This should be taken as clues that this patient may be progressing or may be having a risk of developing Dravet syndrome. There are some scoring systems also. More of that we will discuss when we discuss the epidemiology and of the epilepsy per se, right? Okay. In this case also, in Dravet syndrome also, there is normal development prior to seizure onset. So before the seizure onset, the development is normal. So somewhere in 5th to 8th month time, patients start developing febrile seizures, and after patient has completed 1 year, right, so between the age of 1 to 4 years, patients start developing additional seizure types. Okay, so various other seizure types they start manifesting with. Right? Okay. Now, when it comes to its etiology, one important thing we should know is the role of genetics, right? So the sodium channel SCN1A mutation is seen in 80% of these patients, and that is what even Harrison specifically gives a table, the channelopathy and the epilepsy that are associated. That table I always tell students that it's very important. You can anticipate questions from that. So even if you had not known anything of this, if you had just gone through that table and learned 2-3 points, you could have still ruled out some important closed differentials, and you could have come out with the answer for this question. Okay. Now, when it comes to treatment, I do see this as an important MCQ point. That is why I have listed it up. Fenfluramine is used in the Dravet syndrome patients for preventive purpose, right? Okay. Now, let us go to the next question. A 2-year-old child, same like in the previous question, we have a 2-year-old child who presented with myoclonic seizures. Okay. Presentation is with myoclonic seizures. Right now, at least I could think of Lennox-Gastaut as not the important cause, because we have already discussed myoclonic seizures are relatively rare in case of LGS, right? Parents provide history of febrile seizures. Good. So now we know what we are talking about, right? Which gene may be defective, right? So this is a straightforward question now. If we knew Dravet syndrome, we could have answered this, right? So this is nothing but Dravet syndrome. The mutation here is SCN1A, the sodium channel, right? Okay. Now, I was talking about this Harrison table, right? So, which clearly mentions all these channelopathies and the seizure types that are seen in these patients. For example, the CHRNA4, right? So, autosomal dominant nocturnal frontal lobe epilepsy. Similarly, KCNQ2, right? Benign familial neonatal seizures. SCN1A, he clearly mentions the Dravet syndrome, its association with this mutation, right? So if you are thorough with this table, then you could have easily answered the previous question at least, right? Okay. So I again urge you or repeatedly tell you that tables in Harrison are very, very important, even for INI SS, not only for the NEET SS. Even for INI SS, you can tackle a lot of questions if you are familiar with the tables in Harrison. So don't miss that out. Okay. So now let us go to the next question. All are true about EEG findings in epileptic spasms except, right? So what is this question about? This question is about infantile spasms or West syndrome, right? Okay, so epileptic spasm is nothing but a synonym for the West syndrome or infantile spasm. What is it talking about? Generalized polyphasic and wave discharge. Okay, so this is one option. Electro-decremental response. This is one option. Generalized slow waves and rhomboid pattern. Which one of these are not EEG findings? Okay. This question, we had a little difficulty collecting the options, so I am not sure if this is exactly how the question appeared in the examination, but the way I have framed it, I'll try to answer it according to that. Okay. So this question is about West syndrome or infantile spasm EEG changes, right? So what do we see in EEG in patients with West syndrome? We see characteristic hips arrhythmia, right? This is what we are very much familiar with, hips arrhythmia. What is it? It is a chaotic mixture of high amplitude slow waves and multifocal spikes, and there is one more thing we should always know about is the asynchrony between the two hemicranium. So you don't see the similar pattern in both the hemicranium. So there is a asynchrony and there is generalized chaotic mixture of high amplitude slow waves and multifocal spikes. This is what we call as hips arrhythmia, right? You can compare it with a normal EEG and the hips arrhythmic EEG. Now, one important point is, what is this hips arrhythmia? This is not a ictal EEG, right? So this is an interictal change that we see, right? This is an interictal observation. So this hips arrhythmia is a interictal finding, right? So what happens during ictal phase? So when there is a seizure going on, right? So during that time, there is this decrease in the amplitude and slowness. So whatever these high amplitude changes we're seeing here, that becomes decreased, right? So that is what is known as electro-decremental response. So generalized polyspike and wave discharges are seen. There is generalized slow waves during the ictal phase, and during the ictal phase there is electro-decremental response, right? So A, B, C, these are all true statements. The only thing that is not concerned with EEG per se is rhomboid pattern. This is what is seen in the ENMG in patients of infantile spasms when they are going through the spasms, right? So this is more of a EMG or ENMG finding rather than the EEG finding. So this is the right answer according to me. Okay, now let's go to the next question. Wingerchuk criteria is used for acute disseminated encephalomyelitis, neuromyelitis optica, or multiple sclerosis or MOG disorder. Now this is one important area which MCQs are bound to come. Even for the general medicine part of NEET SS, I tell you MCQs are bound to come. This differentiation between the neuromyelitis optica versus multiple sclerosis versus MOG disorder. Particularly, I want you to learn or pay attention to the optic neuritis and its characteristics between these three disorders. Trust me, in next 2 or 3 examinations, there will be one question appearing on this differentiation of these disorders based on the characteristics of optic neuritis. More of that we will discuss when we discuss this topic proper. But right now, let us address the question. Wingerchuk criteria is used for ADEM, neuromyelitis optica, multiple sclerosis or MOG disorder. I'm sure all of you can easily rule out multiple sclerosis because we know we are following the McDonald's criteria, right? So this option is out. Now differentiating between other ADEM, neuromyelitis optica or MOG disorder. If you're a Harrison follower, and if you have heard me in the live sessions, especially on Unacademy or PrepLadder, you might notice that I always tell you, even if the books do not give the name of the author who proposed those criteria, I make it a point to talk about it because there are possibilities that such questions would be asked, right? So if you are following Harrison, you would notice that in the neuromyelitis optica spectrum disorder, the diagnostic criteria, there is a beautiful table, and at the bottom of it, they have clearly mentioned the publishing author, right? That is Wingerchuk. So Wingerchuk was the one who first published the criteria for the neuromyelitis optica back in 2006, if I remember correctly, or if I can trace out the paper. And then there are modifications. So what we currently see is modifications to his initial criteria. But the team that came out with the modification was also led by. So he remains the primary author for that paper, right? So the right answer here is neuromyelitis optica. And this point or this diagnostic criteria has been discussed in the PrepLadder NEET SS video modules. And this was accessible to you on the app and as well as the notes also, right? Okay, so notes, it is covered already. Diagnostic criteria has been covered. Again, I repeat the point. On all the diagnostic criteria, right, if they're not coming from a specific society or a professional body, then always try to make it a point to see who was the first publisher of that diagnostic guidelines or criteria. That would help you, because in my time also I have seen similar questions where books do not specifically mention the name, but the entrance exam, especially the SS entrance exams, they do ask about these points. This is not something that is not expected. I was kind of expecting this. So I always make it a point that I cover or talk about those names, right? Names are important. Okay, now next. Which of the following drug acts by inhibiting GABA transaminase? This is a pretty straightforward question, right? So the answer here is vigabatrin. The name itself gives you a clue. GABA transaminase inhibitor, right? Vigabatrin, GABA transaminase inhibitor. So the diagnosis, the answer is pretty straightforward. No controversies or no difficulties. So I'll just move on. But yes, those who are actually aiming for the neurology, right? There is one important area to focus on. That is the pharmacology of drugs. For the pharmacology becomes more so relevant for neuro and cardio in comparison to other specialties. I wouldn't ask my students who are preparing for endo to focus or spend 2-3 hours behind metformin to learn about its pharmacology. But when it comes to neuro or cardio, pharmacology is very, very important. So pay attention to every drug, its mechanism of action, side effects. You cannot skip this. You will get 1 or 2 questions for sure from this aspect, and the questions are likely to be little googly. They may not be pretty simple or straightforward. This was a straightforward question, but you can anticipate complicated questions there. Okay. Which of the following is not a modification introduced in 2017 McDonald's criteria? So we know McDonald's criteria is used for multiple sclerosis. We are all very much familiar. We are trying to prove that there are 2 lesions disseminated in space and time. That is the essence of this McDonald's criteria. So McDonald's criteria is there in place for quite some time. The latest modification came in 2017, right? So in 2017, some new things were included. What are those? They included the oligochondral glands. They included the cortical lesions. So in the previous criteria, the cortical lesions were not included. Previous criteria were only including the juxtacortical lesions. So that was included. For progression of the primary progressive multiple sclerosis, yes, 1 year history of progression is required. Okay, so that is also a fair statement. So option D, right, which says symptomatic spinal cord lesions are not included to categorize dissemination in space or time. That is false. This was introduced in 2017. Symptomatic spinal cord lesions were considered or introduced in 2017. So these 3 are particularly important inclusions in 2017 McDonald's criteria. This was an anticipated topic, and my neurology colleague Saful had covered this in detail in the videos. So you can access it also from the PrepLadder notes, right? So he had specifically discussed all these things. It was an anticipated question for us. 2017 revisions to the McDonald's criteria, right? So this was addressed pretty well by us. Specific oligochondral glands were included, right? Then cortical and cortical lesions were included, right? So these points were already discussed. Okay. So those who had gone through the videos or notes, this wouldn't have been a difficult question or a challenging task, right? Okay. Next question. Which of the following is not seen on imaging in normal pressure hydrocephalus? Apex crowding, sulcal widening, basal cistern effacement, and periventricular seepage. Okay, guys, let me tell you a simple disclaimer. I am not sure if the question was exactly like this. And second thing, as of now, even I'm not sure about the answer because there are a little bit of controversies. I will definitely come out with a good answer for this question after refining the options and also talking to my good radiology, neuroradiology friends. But right now, let us just spend some time understanding what this question is about, right? So the question is about normal pressure hydrocephalus, and it is about the MRI, right? It's more about MRI or maybe CT. Apex crowding, sulcal widening, basal cistern effacement, or periventricular seepage. If you're a Harrison follower, right? So Harrison mentions this in his notes, right? So neuroimaging, according to Harrison, in a patient with NPH reveals enlarged lateral ventricles, hydrocephalus, that we're all familiar with little or no cortical atrophy. He says there is little or no cortical atrophy, although Sylvian fissures may appear propped open, so-called box caring. So he calls it that Sylvian fissures may appear propped open, and he calls it as box caring, which can be mistaken for perisylvian atrophy. Okay, so he goes on to say that. And there is one important statement If you're a Harrison follower, probably your answer would have been different. If you're following a Radiopedia, your answer would have been different. So in Harrison, he says crowding of dorsal frontal parietal gyri helps distinguish NPH from other movement disorders such as progressive supranuclear palsy or corticobasal degeneration, in which dorsal atrophy with sulcal widening is common. So he is trying to say that the dorsal atrophy with sulcal widening is not that characteristic of NPH, right? So sulcal widening was one of the option. I'm as of now still not very convinced if I should be going with that. And then there is one study which was properly on the neuroimaging in normal pressure hydrocephalus. So in this study, he goes on to say that according to international guidelines, following are CT or MRI signs decisive for NPH diagnosis and selection of scent responsive patients. Okay, what are those? He says ventricular enlargement, which is disproportionate to the cerebral atrophy. So that Evans radius that we calculate, more on that we will be discussing again. That should be more than 0.3. Okay, that is one which is characteristic of NPH. The second thing he says, there is often association with ballooning of the frontal horns. Periventricular hyperintensities may be seen. Corpus callosum is thinned and there is elevation. So there is a callosal angle which is narrow, 40 to 90 degrees. These are all points that are definitely important for NPH diagnosis. Widening of temporal horns not fully explained by hippocampal atrophy, and aqueduct or fourth ventricle flow wide. Okay. Now again, look at this, what he says. Enlarged sylvian fissures and basal cistern. So he's talking about enlarged basal cistern. Do we consider that as a sign of the basal cistern effacement? I'm not sure. Right. And narrowing of sulci. So instead of saying that there is widening of sulci, he says there is narrowing of sulci and subarachnoid spaces over the high convexity and the midline surface of the brain. So high convexity and midline surface of the brain. That is what we call as apex crowding, right? So if there is apex crowding, maybe in some other zones there is sulcal widening. That is a possibility. So right now I am little undecided about this question's option. I will go through a little more literature. I'll also talk to my neuroradiology friends and then we will come out with the answer, right? But remember now that we have encountered a question, radiology of NPH will remain an important topic for next 2 or 3 examinations, right? So they can ask about this individual signs or they will give you images and ask you to diagnose. So all those are now possibilities. So just goes on to say that we have a new topic to focus on. Okay, now coming to the next question. Neurotransmitter in mesolimbic pathway is, right? This shouldn't be a really difficult question. This is something which is very well known to you. I am sure some of my layman friends may also be able to answer this because there are a lot of social media articles about reward system and how dopamine makes us addicted to something. So layman also may be aware about this, right? Neurotransmitter in mesolimbic pathway. We call this mesolimbic pathway as, what do we call it as? We also call it as reward pathway, right? Now, a very important topic in neurology is the dopaminergic pathways. So if you know the dopaminergic pathways, this answer is pretty straightforward. It is one of them. So dopamine is the primary neurotransmitter. What are the dopaminergic pathways we know? Number one, nigrostriatal pathway. You're all familiar with that. Other than that, you're also familiar with the tubulo-infundibular pathway, which is involved in the regulation of the pituitary, right? Primarily the prolactin secretion, right? So we are familiar with that. Other than that, yes, there are 2 more. Mesolimbic pathway and mesocortical pathway, right? Mesolimbic and mesocortical pathway. So both of them are beginning at the ventral tegmental area of the midbrain and connecting to the ventral. So the mesolimbic pathway is connecting the ventral tegmental area to the ventral striatum, right? It is connecting to the ventral striatum, and we already know the other dopaminergic pathway, right? The substantia nigra to the dorsal striatum connection, the nigrostriatal pathway, which we are all familiar with, right? Then we have this mesocortical pathway that is connecting the cortex with the ventral tegmental area, that is mesocortical pathway. And the tubulo-infundibular pathway we are all familiar with in the regulation of the prolactin. These are all dopaminergic pathways, right? Dopaminergic systems in the brain, and the mesolimbic is the one that we call as reward pathway. Now there are various studies evaluating the abnormalities of the mesolimbic pathway in causing chronic pain or in the role in chronic pain, as well as there are a lot of studies which have studied the abnormalities of the mesolimbic pathway in schizophrenia, right? So this is an important area to focus on. Okay. Now let me take you to the next question. Abulia points to the lesion involving. Options included ventral pons, dorsal pons, temporal lobe or median frontal. Okay. This is also not an unexpected question. So all these aphasias, abulias, so all those are well covered in Harrison volume 1 itself. So if you're just a Harrison follower, still you would have answered this question, right? So what is abulia? The Dictionary of Neurological Science defines abulia as a syndrome of hypofunction. So basically abulia is part of the spectrum of a disorder which are called as disorders of depressed motivation, right? I can call them as DDM, disorders of depressed motivation. So the spectrum includes apathy on one end, and on the severe end there is akinetic mutism. So here the patients usually lack motivation. They may not be actively involved in the volitional activities. So the definition of abulia goes like this: syndrome of hypofunction characterized by lack of initiative, spontaneity and drive. So that applies to both the motor as well as speech. So there is lack of initiation, there is lack of spontaneity and the drive for carrying out such activities. Patients often have apathy and slowness of thought, what we call as bradyphrenia, and blunting of emotional responses and response to external stimuli. This is the definition of abulia. So as I told you, this is part of the disorders which can be grouped under the heading of disorders of depressed motivation. The worst part of it is akinetic mutism, right? So where there is no speech, no movement. Akinesia, mutism. That is the most severe form of the spectrum of the disorder. And on the least, we just have apathy, right? So where there is noticeable lack of motivation that varies from baseline. That is the milder end of the spectrum. So abulia sits in between these two, right? So in abulia, there is more apparent decrease in spontaneous purposeful movement, and this deficit is not as severe as we see in case of akinetic mutism, right? Okay. Now, where is the defect, the site of lesion in case of abulia? So all these symptoms, those who are aspiring for neurology, my recommendation is pretty simple and straightforward. Make a table, make a list of all these neurological manifestations, and make a column where you are mentioning the site of lesion. Google it, look into books, but make a list. This will definitely go in a long way. This will definitely help you to crack at least 1 or 2 questions, and that may be a make or break situation, right? So the site of lesion in abulia, there are 2 important points I want you to know. Anterior cingulate cortex is the most common site of lesion, and in that case usually patients are having transient abulia. If the question is about permanent abulia, the site of lesion is usually medial frontal lobes or basal ganglia or supplementary motor areas. There are some other areas also been described, right? Medial frontal lobes, persistent abulia, right? So this question was about abulia, and the options that go well in favor of the abulia is option C, right? Medial frontal lobe. So that is the right answer. Okay, good. So next question goes like this: select the incorrect match. Option A is adacanumab with headache, risdiplam with spinal muscular atrophy, erenumab for migraine, and ocrelizumab for multiple sclerosis. Which one of these is incorrect match, right? So let me start with this is again a very much anticipated question, right? For me, I would have multiple times told the students who were attending the revision sessions and all that you can anticipate a question on these pharmacology, right? So for neurology, especially when it comes to pharmacology, I told you that cardiology and neurology pharmacology is very, very important. For cardio, pharmacology is more important for the older drugs, right? You should know everything about the older drugs, its action, its complications and side effects. For neurology, I particularly consider the newer drugs are more important than the older drugs, right? So their mechanism of action, where they are used, where they are specifically indicated, all this is very, very important. Okay. So in this question, what are the incorrect matches? Let me start with the option D. Ocrelizumab, definitely we all know about it. It is used in multiple sclerosis. I have discussed multiple times. Yeah, this is the first drug approved by the US FDA for the primary progressive multiple sclerosis. I had told some of my UG students also that you can anticipate a question on this ocrelizumab, asking you which of the following is the first drug approved by the US FDA for primary progressive multiple sclerosis. And that question did appear in the INI CET in the last session, right? So this is the first US FDA approved drug for primary progressive multiple sclerosis. Okay, so this is true. This is not an incorrect match. Now, erenumab with migraine, yes, this is used for migraine. So this is also a known fact, right? So this is a calcitonin gene related peptide receptor monoclonal antibody directed against the calcitonin gene related peptide receptor, right? So we already very well know that in case of migraine pathogenesis, the role of calcitonin gene related peptide is now well established, right? So there we can try to reduce the impact of the Cgrp directly acting on it. So we have those GPUNT class of drugs Then we can also try to reduce its action on the receptor by blocking the receptor using the monoclonal antibody. So erenumab is first of the list, right? So this is also a known fact. Now risdiplam is a drug. In fact, this is the first oral drug approved for treatment of spinal muscular atrophy. Okay. So now here there is one important point for us to learn. This is a first oral drug. So we already had two drugs which were parenteral. This is the first oral drug. And the other point I want you to note is that risdiplam is a RNA splicing modifier. So I will discuss more of it. There is one more question coming with relation to spinal muscular atrophy. So we will discuss more about it there, right? Okay. Now adacanumab, right? This is a drug which is actually a monoclonal antibody against A beta amyloid, right? So it's against a beta amyloid. Now we know what is the amyloidopathy that we should be targeting when we are using this drug, right? So this is approved for Alzheimer's disease. This was recently approved just last year, and that actually stirred a lot of controversies because FDA was said to have bypassed certain stringent rules to facilitate this drug's approval. So that was in the news, right? If you're even not read books, if you've read newspapers, you would be aware about this. Adacanumab, which is approved for Alzheimer's disease, not for headache. And even if you didn't know about this drug, right, this would have been the right answer even in that case, simply because they're just telling about headache without telling you which type of headache, right? So I asked 2 or 3 students whether the option was exactly like this. Mostly they said yes. So if they had mentioned cluster headache or migraine headache or tension type of headache, that makes sense, right? You're talking about a monoclonal antibody and you're just approving it for headache, obviously not a scenario, right? So in that case, even if you don't know about any of these drugs, I would have still gone with option A as the right answer, right? Okay. So just for the record, adacanumab is a monoclonal antibody against A beta. So this is used in patients with Alzheimer's disease, right? So its long-term efficacy are being debated in the practice circle because FDA, there were controversies. I just told you about that, right? Okay. Now risdiplam is a RNA splicing modifier. So this is used in patients with spinal muscular atrophy, right? And the other point to note about is this is the first oral drug approved by US FDA for this indication. Now erenumab is a calcitonin gene related peptide receptor monoclonal antibody targeting the receptor, right? And this is used for migraine. Remember, this is not used for the migraine acute treatment. This is used for migraine prophylaxis. Yes, don't get confused on this point also. This is used for migraine prophylaxis. Okay. There are again some more related questions on this drug, so we will go through that. Now ocrelizumab is an anti-CD20 monoclonal antibody that is approved for primary progressive multiple sclerosis. It can be used in the other variants plus the primary progressive. So this is the first drug approved for primary progressive. Right. Okay. Now let me take you to the question number 10. Wrong statement about erenumab. Right. So we already know a lot about it. It is a calcitonin gene related peptide antagonist. Yes, you can call so because it's targeting its receptor, so it is antagonizing its action. So this is a true statement, right? This is a true statement. Once a month injection, subcutaneous route of administration may cause hypotension. Okay. This shouldn't have been a very difficult question for those who know what is the physiological role of Cgrp. So one important role of Cgrp is that Cgrp is a vasodilator. It's a vasodilator. Now, if you are blocking the Cgrp action, are you going to get hypotension or hypertension? Theoretically hypertension, right? Okay, so this option is talking about hypotension, which is a false statement, right? So the right answer here is option D. Okay, so there are trials which showed that there is slightly increased prevalence of hypertension in patients treated with the erenumab, but again that was not statistically significant in most of the studies when compared to placebo, right? So theoretically it is supposed to cause hypertension. Maybe we should be cautious because this is a relatively new drug. The long-term outcome will tell us whether significant increased hypertension occurs, but hypotension is definitely not a side effect. Right? This won't cause because the Cgrp is a vasodilator. If you're blocking it, how would you cause hypotension? You would end up causing hypertension, right? Okay. The other two statements are true. It is a once a month injection which is given in the subcutaneous route, right? So I have already told you this is for prophylaxis. This is not for the acute treatment, right? Okay. Question number 11. Nusinersen is used in treatment of amyotrophic lateral sclerosis, Duchenne muscular dystrophy, spinal muscular atrophy, or Lennox-Gastaut syndrome. This question answer should be pretty straightforward because this is again a very much anticipated topic. In fact, this spinal muscular atrophy during this pandemic was in the big news, right? So that 16 crore drug, that was about this, right? So we all anticipated that questions would be asked about spinal muscular atrophy, and they have asked a question. Okay, so the right answer for this is spinal muscular atrophy. I'm sure you all know about it. Now, before we move on, we will just spend few minutes to learn a little bit about spinal muscular atrophy, primarily from the treatment perspective. Right? So, we all know that spinal muscular atrophy is due to mutation in SMN1 gene on chromosome 5. So, we know that there are two similarly related, structurally similar genes which produce a structurally similar protein. The one is SMN1 gene, right? The other one is SMN2. Okay, SMN2 produces various length peptides. So the amount of SMN2 product which is similar to SMN1 is very meager. So most of its products do not exactly look like SMN1. So they have a little variation in their sequence. So there are mainly 8 exons in SMN1, right? 8 exons are there, and very often the SMN2 product, the exon 7 is skipped. This is not included. Gene has 7, right? The 7th exon is there in the gene, but this is not included in the final product. And that output, the protein that is produced from the SMN2 without involvement of 7 is not functionally efficient, right? So can we do something about this to start treating patients using or modifying this SMN when they have the SMN1 defect? Can we address this by targeting the SMN2? Right? That is where the role of this RNA splicing modifier, that was risdiplam, right? That comes into picture, and that is where the role of this new generation antisense oligonucleotide ASOs come into picture, right? So this nusinersen, all these nursins or ursins, mipomersen, nusinersen, these are all antisense oligonucleotides, right? So the one that is used here is nusinersen for spinal muscular atrophy. So this is a antisense oligonucleotide drug, nusinersen, right? Okay, we have another approach to treat the disease, that is directly correcting the defective gene, right, by doing a gene therapy. And we have an approved drug, that is what was famous, the 16 crore drug, the wonder drug, right? So that is called as, the gene therapy drug is called as, that was adeno-associated viral vector based gene therapy drug, and the drug was called as onasemnogene aboparvovec. I don't know why such a lengthy naming or nomenclature for this, but that was the gene therapy drug. This is the wonder drug, 16 crore drug, where the public campaigns were running for collection of the funds, right? So this is the drug. Okay, so we know 3 drugs now: risdiplam, nusinersen, and the onasemnogene aboparvovec, right? Okay. So I was talking about this SMN2, right? So SMN2, because of the splicing, the 7th, this one is not included, right? The 7th exon is not included. Now, how these 2 drugs are going to work? Risdiplam, right? So risdiplam, by modifying the RNA splicing, make sure that the 7 is included and you have a proper length protein produced from the SMN2, right? SMN1 is mutated, we're not targeting it. In case of nusinersen, right? Nusinersen works on a intron which is downstream from the 7th exon, right? And it makes sure that the 7 is included, right? So this is an anti-sense oligonucleotide. So this binding to this particular intron stops from this intron interfering in the translation process of the 7th gene. So thus the 7 is also included, and we end up getting a full-length SMN protein. So this is the different mechanisms of addressing the spinal muscular atrophy disorder. Very much anticipated question, no surprise there. So right answer is option C. Okay. Now let us go to the next question. False statement about stroke. This is again a very much anticipated question. So when I was talking about stroke, when we did some YouTube sessions and all, I have multiple times told you there are important tables in Harrison. You cannot afford to miss them. Doing tables is probably the most high yield activity that can take you to your DM seat, right? So there is a table in Harrison in the stroke chapter which talks about the relative risk of various risk factors. Then it also talks about the relative risk reduction after intervening for those particular risk factors, right? So we all know there are some important MCQs also that emerges from this table. Number 1, we all know what is the most common risk factor for stroke, or in other words, if there are 100 stroke patients, what is the most common risk factor that you would be finding in them, right? So that is hypertension. Hypertension is probably the most common risk factor, right? Okay. Then other than that, all these are important. The relative risk of these risk factors, right? Hypertension 2 to 5, atrial fibrillation 1.8 to 2.9, diabetes 1.8 to 6. I told even my UG students that I anticipate them asking you about the diabetes, because from the list, right, that appears to have the highest risk. So an MCQ can be framed. Which of the following risk factor confers the highest relative risk for stroke, right? So hypertension is most common risk factor, but diabetes probably is more potent risk factor, right? That is the conclusion that we can draw from here. Then we know about smoking already. That hyperlipidemia, well, that is also a known risk factor. Then asymptomatic carotid stenosis, right? So there's only relative risk is 2.0, not 20%. The question was actually talking about 20%, right? Okay, that is one area to focus. Then the area number 2 to focus is the relative risk reduction with the intervention or treatment, right? So the another MCQ that can be asked is intervening or treating which of the following risk factors for stroke yields the highest relative risk reduction. So if you can see from the table, you will notice that atrial fibrillation when treated with warfarin probably achieves the highest risk reduction, right? The only thing next that comes very close to this is intervening for symptomatic carotid stenosis when the stenosis is 70 to 99%, right? The benefit is quite less in comparison if you are intervening for a symptomatic carotid stenosis when it is 50 to 69% of the stenosis, right? Okay, so I had told some of the students that this is what I anticipate. They may ask you the highest relative risk reduction can be achieved with intervening for which of the following risk factors. Instead, they came out with a question where all these points are mentioned. So let us take them now. Right, okay. Warfarin in treatment of atrial fibrillation, 68% relative risk reduction, right? So true statement, we are very much familiar with this point now. Smoking relative risk of 1.8, I think if you remember the table, yes, this is true statement. Diabetes relative risk 1.8 to 6, this point I have discussed, so this is a true statement. Now asymptomatic carotid stenosis, the relative risk is 2, not 20%, right? And generally relative risk is not expressed as percent, right? So that means that this is the right answer, right? Option D is the right answer. If they had mentioned it is 2, then again that would have become a true statement. Okay. Now before I discuss the next question, right? The message is loud and clear. The tables in Harrison are the gold mines of MCQs, right? That also makes the examiner's job easier to frame an MCQ. When you read a textbook, when you read the text, when you're trying to frame a question, I have made that attempt to frame questions for universities and frame questions for the app Q banks for various platforms. And the problem is when we're trying to frame the questions from the text, we have to go through a lot more literature that actually I have to spend around 40-45 minutes to frame one question so that there are no controversies after that. But if you're picking it up from tables, it is quite easy because table segregates the data or information in a nice way. And it is really easy for an examiner to frame MCQs. And that is why the flowcharts and tables are very, very important, right? Flowchart, again, framing an MCQ from the flowchart is very easy for examiner, because there is a nice flow of the process, right? So they can dissect at one point and ask you what do you do next, right? I will give you all the information for you to come to that particular point and then ask you what would you do next, right? So again, very easy to frame. Now if I have to go through the whole chapter and the treatment or the protocol from the text and frame a question, I will be still left with confusions, right? So if you are familiar with all the protocols or flowcharts that are present in Harrison and the tables, right, you have done yourself a great job. Okay. Let me now get back to the question. Patient with hemiparesis within the time window for thrombolysis. So patient has presented with hemiparesis, he is within the time window for thrombolysis. Initial investigation to be done. Okay, so we know what is the time window for thrombolysis, right? So 4.5 hours. So this patient is presented within 4.5 hours. So you would be considering this case for thrombolysis if there is no bleed, right? This should be a very simple and straightforward question. There shouldn't be any confusion for an exam going student. Just let us go into the options now. Initial investigation, right? MRI brain, obviously no, right? MRI brain would consume 45 minutes to 1 hour, so definitely not the right thing to do. ABG, oh my god, if you're going for thrombolysis, why ABG? You know, it's in fact a contraindication. ABG, like there are some guidelines which say ABG even done within last 7 days from a non-compressible site is a contraindication. Right? Arterial puncture within previous 7 days from a non-compressible site, for example subclavian. You may ask me who will do subclavian ABG, but inadvertent punctures are very common when you're trying to put a central line. You would have punctured. So if it is within the 7-day span of the onset of focal deficits, well, no, it's a contraindication, right? So this is not the right answer. Then let me take you to option C. Contrast CT, definitely no. If you're going for CT, we are mainly doing it to rule out bleed rather than pick up infarct, right? So that much we are very much familiar with. So contrast is not required. So this option is ruled out. ECG, non-contrast CT and platelet count, not necessary, right? At least ECG is not necessary. Now coming to the option B, this is the right statement. Non-contrast CT, blood pressure test you need to record. You need to record blood glucose because hypoglycemia is a contraindication for thrombolysis, and hypoglycemia might explain the deficits that you're seeing. So first correct that. Make sure that this is truly an infarct. Hypoglycemia is just a co-occurrence and you've treated that, then you can consider. So you need to do blood glucose, right? So option B is the correct answer here. Non-contrast CT, BP and capillary blood glucose. Okay, let's go to next question. True statement about retinal migraine. Well, this is one question which is really difficult to address from Harrison. So for me also, I had to go through some literature to come out with the answer. I had not really focused on, I should apologize, I had really not focused on the subtypes of migraine so much. Because in Harrison, whether you're seeing from the volume 1 or whether you're seeing from the volume 2, there is a table classification of migraine and then some basics are spoken about, right? But I know you guys are preparing for neurology, so you should be very well versed with the migraine, right? Okay, so the true statement about retinal migraine is there is usually unilateral visual loss with or without headache. That is characteristic, right? So remember this point and then spend some time learning about retinal migraine. Okay, as I learn more about retinal migraine, definitely I will frame some MCQs and put it on the PrepLadder's Facebook group so that we can learn more about retinal migraine. Okay, this question was pretty straightforward, no controversies and no difficulties there. An young male with acute gastroenteritis for 3 days presented with seizures. MRI is given below. Now, I did get some conflicting words from the students. Some students said that it was very typical CT that was downloaded from the internet, and they shared that particular Google screenshot. And then some students were not agreeing with that observation. So I'm not really sure. But the way I have framed it from the information collected, okay, this makes some sense. A young male with acute gastroenteritis, even if that said female, okay, I wouldn't have bothered. Young is important here. Acute gastroenteritis for 3 days, presented with seizures, and we have the MRI image. Okay, so it looks like a contrast image. The question is asking you what is a false statement. Avoid mannitol and glycerol. Antiplatelets are to be started. Anticoagulants plus anticonvulsants are to be started, or antiplatelets and anticonvulsants, right? So this is the combination that we should be considering in this patient. First of all, what do we have in the image? In the image, we can see that there is a bleed. Right? In the image, we can see that there is a bleed. And we can notice that there is an empty delta sign. Right? An empty delta sign. So this is basically a cortical vein thrombosis with venous infarct and then subsequent hemorrhagic transformation, right? So this is a venous hemorrhage and cortical vein thrombosis. So the mainstay of treatment when there is cortical vein thrombosis, even if there is a bleed, definitely it has to be about anticoagulants. There is no per se role of antiplatelets, right? And because patient has already developed seizures, we have to consider giving anticonvulsants, right? So mannitol and glycerol per se may not play an important role here. Antiplatelets, no role. That's what I told you, right? So the right combination here is anticonvulsant plus anticoagulants, right? That is the right combination to treat these patients. Okay, let's move to next question. Okay, so the next question is this: hypertensive with focal deficits. Okay, we know hypertension is an important risk factor for stroke. So patient has focal deficits. CT shows basal ganglia bleed, anticipated site of bleed in a hypertensive patient, right? Scoring system used for prognostication in this case includes all except. Very much anticipated question, right? I keep stressing with the role of scoring systems. At least one question is what I anticipate, and in this series, I think there are multiple questions which are centered around the scoring systems. Again, I'll tell you what is the reason why we see so many questions about scoring system, because that makes it easier for an examiner to frame a question. They can ask you which of the following is a component or is not a component. If you have seen my PrepLadder lectures, I had done a specific separate video for the ICU scoring systems, because again, I was anticipating similar kind of questions if you're preparing for critical care or if you're preparing for the NEET SS. Very much anticipated question, anticipated area to focus on, right? Okay, so when you read scoring system, know the name of the proposer or the first publisher. If it is not given there, if it is coming from a professional body, fine, like American College of Rheumatology or something, it's fine. Okay. Then the second thing to note is what are the components. If you cannot remember the scores ascribed to those points, it's fine. If it is a very common disease, right, for example, atrial fibrillation, stroke, TI, these are all common disorders, right? At least for a neurology side, it is very, very common disorder. Those things, if there are scoring systems, be aware about all the components. If it is a relatively rare disorder, then probably the scores are not important for us, but the components are definitely important. That much you have to remember. The components, proposer or the name of the person who first came out with the scoring system, and for selected disorders, the scores are ascribed to individual findings, right? Okay. So what is the scoring system we're talking about in this question? Intracranial bleed, right? So we're talking about ICH score. This is there in Harrison. This is not something that is like, I would say this should be expected even by the medicine aspirants, right? So those who are aspiring for the NEET SS general medicine stream, not only concentrating on the neurology. It is important for all the medicine stream students, right? Okay, so let me take you to the ICH score. What are the components here? GCS is one of the important component. Then the blood volume, right? The intracranial hematoma volume, that is a component. Then whether there is intraventricular hemorrhage, whether the blood has seeped into the ventricles, right? So that is one of the finding. Then it is talking about infratentorial origin, whether the origin is infratentorial or supratentorial. Okay, that is the fourth component. Age is part of it. So we have 1 GCS, 2 ICH volume, 3 whether there is intraventricular bleed, 4 whether there is infratentorial in origin or supratentorial, and 5 A. So 5 components in ICH score, right? The eventual score would be in the range of 0 to 6, right? So higher the score, we know poor is the prognosis, right? Okay, now what is this question asking about? Which of them is not a component? Site? Well, the scoring system was talking about infratentorial or supratentorial, so we need to know site. So this is a component, right? Okay. Now, age was definitely a component there. If you remember, 80 and less than 80 or more than 80. So age is also a component. Volume of the bleed, less than 30 ml, more than 30 ml was a component. So this is also true, right? So you don't find duration of symptoms or bleeding anywhere in the ICH scoring system. So the right answer here is option D, duration, right? Okay, let's move to the next question now. False statement about mechanical thrombectomy are all except, right? Okay, this is also a pretty much anticipated question, right? Safal had covered at length about the mechanical thrombectomy in patients with stroke, the carotid stenosis. He had discussed it at length, right? So just let me take you to the question. False statement about mechanical thrombectomy are all except NEET SS score more than 6, aspect score more than 6, should be done within 4.5 hours of onset of symptoms, or should be done 6 hours of onset of symptoms, or within 6 hours of the onset of symptoms. Now, for me, this becomes little clear here. I have to choose one between option C or D, right? Because both are essentially talking about the same thing with a different time frame as the yardstick, right? So I have to choose between C and D. I'm not sure if the question was exactly like this, but at least in this question, this is clear. C or D may choose karna hai, because these are like pretty straightforward. Okay. If you have already followed the PrepLadder videos, this was kind of anticipated. So Safal had covered in detail mechanical thrombectomy, right? So he had mentioned that 0 to 6 hours is what is the ideal time frame. So if the patient is presented within 6 hours, you can go for mechanical thrombectomy from the onset of symptoms, right? So option D was the right statement, and option C, that was talking about 4.5 hours, becomes the nonsensical statement there, right? Then he had also mentioned that it is ideally more suitable for patients who have the block in the M1 segment of the middle cerebral artery or the terminal portion of the internal carotid artery, right? So mechanical thrombectomy is more feasible or more ideal when the terminal segment of the internal carotid artery has the thrombus, or the M1 segment of the middle cerebral artery, right? So this is also another important point now we should know for the next examination, right? What is the ideal site from which the mechanical thrombectomy can be attempted? The patient's age should be more than 18 years, and when you're doing this NIHS or aspect score, it should be more than 6. So all these aspects were clearly described with even the level of evidence being mentioned, right? So if I had gone through the video, this wouldn't have surprised you, right? Okay. The next question is, which of the following scoring system helps in assessing the stroke risk following TIA? Right. I don't need to really discuss this question. This is a pretty straightforward question and anticipated exam finding. Right. Scoring system that is used in assessing the stroke risk following a TIA is definitely ABCD2. Right. So this is also one more important scoring system. Now this is one scoring system where you should know the components. Right. ABCD2. You should know the components and you should know the scores because it's a commonly used scoring system. We should be aware about it. Okay. Now let us go to next question. A 75-year-old diabetic, hypertension and atrial fibrillation. Which of the following in this case is not a risk factor for stroke? This is again a pretty straightforward question. This is about the stroke risk in atrial fibrillation. Right? Stroke risk in atrial fibrillation. So we know atrial fibrillation is a risk factor for stroke. What additional contributors? And how do we address these questions? Simple, right? Chad-Vask score. Right? So options included DM, hypertension, age and gender. If you remember Chad-Vask score, the bottom of the Chad-Vask score, you will notice females are ascribed 1 point for the risk, right? So female gender is considered as a risk factor. This question is talking about a male patient, right? Okay, even I have forgotten, but students had clearly told me that the question was about a male patient. So when they had mentioned male, obviously gender becomes the not a risk factor, right? So if it was a female patient, yes, that would have become a risk factor. Okay, so Chad-Vask is again a very important scoring system that you should be well versed with, right? All the scores, not only the components, right? So Chad-Vask per se is a mnemonic. It is not really difficult to remember the components. Neither it is difficult to remember the score because it is clearly mentioning it, right? So CHF or LVEF less than 40%, 1 score. Hypertension, 1 point. Age more than 75, right? One of the most potent risk factor. So in this question, patient was 75-year-old. So age was a risk factor. Hypertension, diabetes, we already know about it. Diabetes, 1 point. Age more than 75, 2 points, and 65 to 74, 1 point, right? So age is an important risk factor. Other than that, previous history of stroke, TIA or thromboembolic events, 2 points. So these are the important areas where 2 points are given, right? Age and stroke. Vascular disease elsewhere, 1 point, and female gender, right? Now, if you remember, even in the previous NEET SS, the general medicine side question, there was a question about the risk of thyroid cancer and they were asking about which of the following is not a risk factor. So there also it was about gender, male gender, female gender. Male gender was a risk factor there, right? So female gender was a relatively less risky. So same thing, whenever we talk about the risk factors, especially if it is a scoring system, always pay attention if there is gender involved in that, right? So this is one more lesson that we learn from these questions. Okay, let me go to the next question now. All of the following are trials related to thrombectomy. I have already emphasized this. Trials, particularly stroke related trials, are very, very important for neurology, right? And we had addressed those points. Options included Swift Prime, Extend A, Escape and Hamlet. So these three you might already remember. I had shown you that we had covered these: Swift Prime, Extend A and Escape, right? So these were all about the thrombectomy, right? These were all about the thrombectomy. So the trial that is not about thrombectomy here is this is about thrombectomy, this is about thrombectomy, this is about thrombectomy. Hamlet. So Hamlet was the trial for hemicraniectomy in patients with life-threatening cerebral edema following a middle cerebral artery occlusion, right? That was the Hamlet trial. So that was the right answer in this case. So trials, what was the objective of conducting the trials? What was the end point and conclusion? This is something that you should know, right? You can definitely make a notes out of it. And I also try to share the important notes as and when I make them. Okay. Now let's go to the next question. Which of the following questions are asked to a patient in NEET SS score? Right. Okay. So again, one more scoring system. Important topic for sure. NEET SS score and aspects. These are something which we all know are important, and a lot of questions will be asked about it in the SS papers, right? So we don't ask aspect score related or NEET SS score related questions to undergraduate students. I mean the two students who are writing for the NEET PG. At best, we will we will be asking about which of the following is used for functional outcome assessment or prognostication. Those kind of questions, right? The components and scores are usually not asked to them. But for you, yes, this is a very important topic. Which of the following questions are asked to patient in NEET SS score? Month and age, name and month, name and time, or name and age. Okay, so this is basically a question in NEET SS score about the assessment of the level of consciousness. So the level of consciousness in NEET SS score, NEET SS scoring system is assessed in 2 levels, right? The 1A, where we are talking about whether the patient is alert, whether he is responding, not alert and requires repeated stimulation for attaining the alertness, or unresponsive to stimulation or response with only a reflex. only with a reflex, right? So this is one thing. The second thing is, if they are alert or responsive, you are also asking them questions. What is your age and what is the month? Right? What is your age and what is the month? This is the question that we would be asking them. And the question that was asked in the INI SS was particularly about this point, right? Okay, so we know month and age is what we're asking, right? What is your age and what month is this, right? So option A is the correct answer. So this much of attention to detail is required if you are preparing for the INI SS. Even for NEET SS, I would consider this important, right? So simply make a list. If this is a common disease and there is a scoring system involved, and that too mainly that facilitates decision making, you must know the components and the score, because you can expect clinical STEM MCQs where some information about those scores are given and then you have to come out with a conclusion, right? So remember this now. Now let me take you to the next question. Which of the following is a monoamine oxidase B inhibitor? Sufinamide, rotigotine, apomorphine, or opicapone? This again shouldn't be a no-brainer. I have already told you, neuro students should particularly know new drugs. If you had heard me and if you had gone through all the new drugs, they shouldn't have been a very difficult question at all, right? So it is the sufinamide, which is a monoamine oxidase B inhibitor, right? Sufinamide. So we know older drugs, selagelin and rasagelin. Sufinamide is a relatively new drug. This is in markets from 2017 or 18, and this is primarily used for reducing the off time, right? So pharmacotherapy of Parkinsonism is a very, very important topic, and especially the new drugs are even more important, right? All the side effects, manifestations, cautions, all that we should learn. Okay, so this was a relatively easy question. Sufinamide is the drug which acts through monoamine oxidase B inhibition. Okay, the next question is about pentanucleotide repeat disorder. Which of the following is a pentanucleotide repeat disorder? I'm not sure. The question was like this, or they had asked which of the following is not a pentanucleotide repeat disorder, but from the options we have collected, it seems like the question was like this: which of the following is a pentanucleotide repeat disorder? Now all these repeat disorders, right, the trinucleotide and all, for neurology they are very, very important. There are tables in Harrison from where these points can be compiled, and I always keep telling students, the CAG and the non-CAG trinucleotide repeat disorders are an important area. Means they will usually ask questions, which of the following is not a trinucleotide CAG repeat disorder. So I told the students in the Telegram group that you can anticipate these kind of questions on this. A very similar question has been asked, right? So we know that there are some repeat disorders, particularly, see, all these are the CAG repeat disorders: Huntington's, Fragile X, and myotonic. Spinocerebellar ataxia is the one which, like spinocerebellar ataxias, I think the option they had mentioned was the type 10. Okay, so when it comes to spinocerebellar ataxias, most of them are the CAG repeat disorders with exception of 8 and 10, right? So I want you to remember 8 and 10. Okay, what are 8 and 10? 8 is a CTG or a CTA repeat disorder, and spinocerebellar ataxia is a, you can remember 5-ATTCT, so it is a pentanucleotide. All of them, rest of them are trinucleotide, right? 1 to 7 are trinucleotide, 8 is also trinucleotide, but it is not a CAG, it is a CTA or CTG repeat disorder, and then rest of them again are like the spinocerebellar 12 and 17, they are also CAG repeat disorders, right? So if you remember 8 and 10 as an exception, that kind of serves the purpose, right? And 10 is specifically pentanucleotide repeat disorder. So the right answer here is option D, right? Okay. Now next question. This is again one more area which I have already framed 1 or 2 MCQs on the PrepLadder Q Bank related to this, anticipating that this would be an important topic. Okay. True about anterior ischemic optic neuritis. So in Harrison volume 1, he covers a little bit about the anterior ischemic optic neuritis as well as the posterior ischemic optic neuritis and the differentiating features. And he also talks a little bit about the arthritic and non-arthritic anterior ischemic optic neuritis. And also I think he talks a little bit about the sildenafil and its involvement. So I might have framed, if I remember correctly, I might have framed 1 or 2 questions around this topic in the PrepLadder Q Bank. Okay, so let us address the options here. True about anterior ischemic optic neuritis, AION. Hyperemic optic disc, steroids are helpful in all cases. Visual loss occurs in vertical meridian or painful vision loss. Okay, even if you're a Harrison follower, this must be very much clear to you. In case of anterior ischemic optic neuritis, you are getting a painless vision loss. Okay, so that is what Harrison clearly writes about. You are getting painless vision loss. That is point number 1. Okay, the second point I want you to learn is, in Harrison, he divides them into the anterior ischemic optic neuritis. So when we say anterior optic neuritis, it is primarily the disease which is affecting the disc. Okay, so disc is one that is affected. Right? So disc usually becomes pale. Pallor of the disc is an important clue to think of anterior optic neuritis. So hyperemia is not seen there. So this is also a false statement, right? So option A is a false statement. Then option D is a false statement. Now coming to option B, steroids are helpful in all cases. Okay, if you remember Harrison, he says arthritic and non-arthritic. So steroids are not helpful in case of non-arthritic. Arthritic is usually, right? So we are dividing them into arthritic, AION, and non-arthritic, right? So when I say arthritic, most of them are secondary to giant cell arthritis, right? So their steroids may be helpful, right? So their steroids may be helpful. But the most common type of, this is again an important MCQ I can sense for the upcoming examination. Most common type of anterior ischemic optic neuritis is indeed non-arthritic type, right? So that means the option B is a false statement because steroids are not helpful in all cases. In fact, steroids are not helpful in majority of the cases. In a minuscule cases, they are helpful, right? So this is a false statement. So we are left with option C, vision loss occurs in vertical meridian. Okay. For a person like me with a medicine background, I really didn't know that the vertical meridian loss of vision occurs because Harrison only talks about painless vision loss, right? And he says that there may be a staggering loss of vision. Mostly it is sudden, but sometimes sudden initial loss and there may be little staggering vision loss. He doesn't talk about vertical meridian, but by ruling out option A, B and D, I would have answered option C as the right answer here. Okay. Now let us go to the next question. I have already summarized the important differences between the optic neuritis and non-arthritic as well as arthritic. Important point that we should know it is about age, right? Because arthritic means we're talking about giant cell arthritis, which is usually common in more elderly, right? So non-arthritic might be seen in after 40, 50 years, but arthritic is usually seen furthermore, right? 65, 70 plus elderly group, right? The other thing about arthritic is, arthritic may be uni or bilateral, but non-arthritic is very often unilateral. Right? It's very often unilateral. Right? This is something important. You should go through this table for sure. Okay. Now let me take you to, so as I have told you, it is a disease of the optic disc, right? So in acute phases, in non-arthritic as well as arthritic, there you will notice that there is disc edema, right? And small disc to cup to disc ratio. So disc edema and pallor is what we would expect in case of anterior ischemic optic neuritis, not hyperemia, right? Okay. And in this table, the most common being non-arthritic, he has mentioned that it is associated with altitudinal defect. That is what the option was talking about. Visual loss occurs in vertical meridian or altitudinal defect. Okay. So from Harrison, this is pretty straightforward, not a very difficult question to answer if you know that this topic is important for us. Okay. So thank you guys. I will compile some more questions which students are still sharing, and we will be coming out with one more session or at least a quick note on other important topics that are important for the neurology, right? Similarly, I will be coming out with the recall sessions for the other subjects, including the general medicine part. Thank you for listening till now. Stay connected and study well. I wish you all the best for the upcoming examination. Thank you guys.